Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University in this wonderful studio at the Alan B. Levan Innovation Center, which is a collaborative venture between Nova Southeastern University and Broward County Commission. And we're very proud to have Dr. Mark Shachner, who is the medical director of the Heartburn Center in Coral Springs, which is part of the Broward Health system. And he is involved in many surgical procedures. He does obviously robotic and minimally invasive surgical techniques. And we're going to talk specifically about, if I'm not mistaken, a magnetic sphincter augmentation for GERD. But we're going to talk about other things as well. So welcome, Dr. Shachner. Welcome.
Well, thank you very much. It's great to be here.
Dr. Shachner, really, tell me what the medical facility is, the Heartburn Center in Coral Springs.
Reflux is such a common problem where we have about 14 million people are taking medications for it daily, and about 40% of them are unhappy with their treatment. So they can go to their regular doctors. It's such a common problem. Your medical doctor is seeing it every day. Your gastroenterologist is talking to you every day about it, and they kind of take it for granted. But there's so many advancements in the treatment in the last 10 years for reflux that in order to get a patient's care up to the next level, we've developed a center. It's really the only hospital-based reflux center in South Florida at Coral Springs, where we can evaluate patients who have the complaints of heartburn. And there we can see really what is causing those symptoms, because the symptom of heartburn is not always caused by what most people think of as reflux or GERD. So one, we had the resources at the hospital to make a diagnosis of what the patient's symptoms have been caused by, and then we can develop a treatment plan. And we offer multiple different treatments that we tailor for the specific patient's problems.
Let me ask you, the reason we have this show, and we're in our 22nd year, but we get questions from our viewers. And I try to seek individuals such as yourself who have expertise and who have a feel for the community to answer these questions. And one of the constant questions we get relates to what you might call heartburn, but it's really GERD. It's to most of the questions. In other words, I'm lying down, I've changed my pillows, I've done this, I've done that, but rarely do I hear from them the real cause and effect of what's created this problem. So I said, let's get somebody who is an expert. And lo and behold, we found Dr. Mark Shachner. And I'm very pleased to have you here. So what I would like to hear from you is a lot of the things that show up are really not oversimplistic as far as the anatomy is concerned, but oversimplistic in what people constantly communicate through television advertisements, through just walking through and grabbing things off shelves. So it's all yours.
Reflux is simple in a way, and its treatment is simple to understand why it should work. But people have to understand what reflux is, what the medications can do for you, and when you may need some other alternatives. So reflux itself, or GERD, or gastroesophageal reflux disease, is when the contents of the stomach come up into the esophagus, the swallowing tube. That is what reflux is. We have medications that people take. They're called PPIs or H2 blockers, things like omeprazole and Prilosec, the most common medications used in this country. And what they do is they changed the contents, the character of the contents. They changed the acid in the stomach contents to non-acid so that when it comes up into the chest or into the esophagus, you don't feel it. It doesn't stop reflux. It just stops the feeling of reflux. And for many patients, that is fantastic. But it doesn't change actually what's happening. Another part of reflux is not just the burning, but the sensation of food coming up into your esophagus or your throat, regurgitation. The medications don't change that as well at all. So that's part of why people still can have symptoms despite taking their pills. And we recommend that people should change their lifestyles to some degree to help reduce reflux, to reduce the ability of contents of the stomach to come up into the esophagus. Eat smaller meals, lose some weight. Don't eat things that are irritating like acid-containing things or citrus like pineapple. Don't lay flat at night. Sleep on a pillow or elevate the bed. That can reduce acid from coming up or anything from coming up into the esophagus. And things can come up into the esophagus so high that they can make you cough. They can make you breathe in things and make you feel like you're drowning. So it's a very serious disease. But on the other hand, you can have these same symptoms and it's not even reflux. So of course, the medications you take or what the doctors prescribe to you may not help at all. So one, you should help yourself by changing your lifestyles to some degree. Take the medications as recommended. But if you're still having symptoms, you need to make sure that it's not just your reflux isn't being treated enough, it's that you don't have some other problem. And other problems include esophageal cancer and something called achalasia where the muscles don't work properly, or pancreatitis, or your gallbladder could be acting up. So pneumonia, all kinds of things that cause similar symptoms. So that's why if you're not treated well with a pill and lifestyle changes, you need to be further evaluated. And that's what we can do at the Heartburn Center. So clearly, if we want to find out if somebody has reflux. That is, somebody has acid coming up into their esophagus. So we can have them stop their medications. And we have several tests that can actually measure the acid coming up into the esophagus. So we could tell you, hey, your symptoms are caused by reflux because you have 5 times more reflux on a daily basis than the average person. Or we can say, hey, you know what? You don't have reflux. You have some other problem. Let's do some more testing and find out what really is the cause of your symptoms. And those are things we can do at an integrated heartburn center.
You know, we get questions from our viewers. That's how we really present this show, and we have been for 22 years. And we usually get comments. People say, well, my doctor said I shouldn't eat late at night, so therefore it's fine. But then there was a question, or it was a query, because we don't give healthcare advice, or we just pass on the questions to people like yourself that we interview. And they say, my nutritionist said that I shouldn't be taking some of the products that are sold over the counter that reduce the acid content of your stomach, because you won't have the benefit of it being digested by the intestinal flora, et cetera, et cetera, et cetera. Can we talk about that for a little while?
Yes, we can. And remember, I'm a surgeon. Now I do the testing for reflux. I do tests to check for acid coming up. I do tests to look for the function of the esophagus to make sure that weaknesses in your swallowing tube aren't causing your issues. But I do a lot of surgery, minimally invasive surgery. We do it robotically. It's outpatient with small incisions. But I have an orientation to trying to fix this problem when appropriate with procedures, not just with pills. Yet, I have to say that the medications, when taken for the right reasons, are safe. They do have side effects. Every medication we have, as you know, does have side effects. You can get polyps that develop, little tumors that grow in the stomach, but they don't really cause problems. We can maybe have a little increased risk of COVID, but it's a very small risk when you take these medications or some other infections such as pneumonia. But overall, although there have been studies that show an increased risk of death and dementia and renal failure, those risks are really small if they truly exist. But if you can get off those medications, or if you don't even have reflux and don't need that medication, then why take a medication that even has a small risk if you're not really getting a benefit from it? Then that risk-benefit ratio doesn't make sense anymore. So the medications are safe, but if they're not helping you, please make sure that you really need them and that they're really treating a problem you have.
They have a slight hiatal hernia, all right? How does one, like, such as yourself, deal with something like that? Because obviously the hiatal hernia is created by some cause and effect, and you tell me how it's created.
Well, I think this is the coolest part of reflux is some of the anatomy and physiology, the way we've learned how the body is put together and works together. So we have a valve between the esophagus and the stomach. It's very complex. It's made of all kinds of muscle fibers, but the muscle fibers don't just come from the esophagus and the stomach. They come from the diaphragm too. So the diaphragm and the lower esophageal sphincter in normal people are together, so that when you take a deep breath, your diaphragm, it pinches, it tightens up. That's what allows us to breathe, but it also tightens around the lower esophageal sphincter. So it prevents food from moving up into the chest. When you take a deep breath, air comes in through your lungs, but food shouldn't be coming up into your esophagus. So the diaphragm and the esophagus are tightly grown together when you develop. But any place where a body part goes through a hole, so we have that in the belly button, where your mommy's vessels went through the belly button into the abdomen, you could get hernias there. The opening, there's a natural opening to allow the esophagus go through the diaphragm, to let your mom's belly vessels go through your abdominal wall, that allow your blood supply to your testicle to go through to the groin, to the scrotum. That gives you inguinal hernias. Every place in our body where we have a natural opening, well, you can imagine it being too tight, but it could be too loose and loosen over time. The opening of these openings, the loosening or expansion of these openings is called a hernia. So a hiatal hernia is where the diaphragm, which used to be tight around the esophagus, is now loose. And that looseness allows the stomach to go up into the chest. And as it goes up into the chest over time, that hernia gets bigger and bigger, and more stomach goes up into the chest. And as I just told you, the valve of the lower esophageal sphincter between the esophagus and the stomach depend on the diaphragm. So once that valve moves away from the diaphragm, you're apt to having more and more reflux. So you cannot help a patient's reflux unless you also fix their hiatal hernia. So people have reflux, but not all of them have hiatal hernias. Most patients with a hiatal hernias, however, will have reflux. And those hernias get bigger over time. So over the years, your reflux will get worse. So a lot of my surgery is based on repairing the diaphragm and getting the stomach out of the chest and into the abdomen. And with that, we do an anti-reflux procedures as well. But just getting the stomach in the right place and the diaphragm tightened up goes a long way to helping people's reflux.
And I would assume, because I know that you do a lot of robotic and minimally invasive surgical techniques, so I would assume that that's how you get to repair that area. Is that correct?
That is correct. So minimally invasively, we have 4 small incisions. We use a camera that I control, but the robot helps prevent any shake. It allows for a 10 times magnification. I have small instruments I control with enormously high precision. And so we can identify the nerves in that area so clearly. It's just beautiful. We can repair the hernia. At the Broward Health Heartburn Center at Coral Springs, we even have devices, something called EndoFlips, brand new measuring device, where we can close that diaphragm and measure how tightly we make it with this balloon, so we don't make it too tight or too loose. So a very important part of treating people with reflux is fixing those hiatal hernias. But that's not enough. You have to make the sphincter stronger because it's gotten weaker from being up in the chest. Or people are naturally who have reflux without a hiatal hernia, they have a weak valve. So we need to augment that valve, and that's one of our newer procedures. I mean, to me, I've been doing this for 10 years with this specific procedure, but magnetic sphincter augmentation, or LINX, with the repair of the hiatal hernia is one of my common procedures I do to stop reflux.
Let me ask you, we had I guess, a query from one of our viewers about the fear of having the test prior to having any surgery. In other words, they worry about anesthesia, for example, which is a common comment that I hear over the years. Would you explain how you would know there is a hiatal hernia?
Yes, well, the most common way that people are diagnosed are with endoscopy. So endoscopies where we put a tube with a camera on it through the mouth and we look down the esophagus into the stomach. And of course, it's easy to miss a hiatal hernia if you don't have a special interest in identifying it and measuring it. But that's a common way that it's found. And in fact, that endoscopy, which is, I do that, but it's also performed by the gastroenterologist, is a very important test in patients who have symptoms of heartburn, including burning or difficulty swallowing or pain with swallowing. Those people should have an endoscopy, and there the hiatal hernia can be identified. But I could use endoscopy to even repair reflux and some hiatal hernias. We do an endoscopic procedure called TIF, or transoral incisionless fundoplication, at the Heartburn Center at Broward Health, Coral Springs. So we have so many options to address this that's for a really small hiatal hernia and for reflux. But we have so many ways to address the hiatal hernias. But it is important to get the right diagnosis, and endoscopy is very common. CAT scan is also commonly used and identifies hiatal hernias. And some hernias are so big you could see it on a regular X-ray.
Really? That's something that, it's something that you're saying to me that I was not aware of, but I'm sure that the viewers were not aware of it either. But there was this, like I said, there are more than one or two comments about, well, I really don't like take anesthesia. We hear that all the time when we hear it all the time relative to colonoscopies. I mean, all the time. It's not just the prep. It's, well, I just don't want to be put out, et cetera. I don't know I guess there is some fear, and I'm not judging that fear of the people who are asking the questions, but it does come up very often.
Sure. Well, for testing, we have certain tests that can be done without anesthesia. We use a tube that goes down the nose, so that's uncomfortable. We numb it up, and people swallow a bunch of times, and that helps measure if food's going down properly and the function of the esophagus. We can use little wires that we put down into the esophagus that also measure fluid and acid coming up into the esophagus, and they require no anesthesia. In upper GI, where you drink liquids and they take x-rays of that liquid going down, can also diagnose many problems with the esophagus, including the hiatal hernia. And you don't need any anesthesia. But the anesthesia we use for endoscopy or for our balloon pressure measurements or putting wireless devices in to the esophagus that measure acid, that's done under very safe conditions with anesthesia monitoring. It's done with medications that wear off very quickly, and it's very safe. So I think it's reasonable to be concerned, and you want to make sure you're in your best shape before you have any anesthesia or medications. But really, These are such safe conditions for a patient to be in. So I understand the fear, but most of the time we can allay the fears by the knowledge that the patient's going to have more comfort by one, being treated early, being diagnosed properly, and being diagnosed in a way that's comfortable for the person who's having the treatment.
Let me ask you this. We have so many people. We have the highest number of people in the state of Florida over the age 70 in the United States, and I would assume that the issue of multiple medical issues. Hopefully, I wish everybody well, but it occurs. That this is not an uncommon thing to have GERD or heartburn, and like I said, we just spoke about hiatal hernias. So, do you find that to be such now that you're in this massive practice here at the Broward Health's facility in Coral Springs?
Sure. Well, reflux or GERD is very common in the young age group, but as we get older, the incidence of hiatal hernias increases. And the problem is, if your symptoms are from a large hiatal hernia, they tend to get worse. So I see patients in their 70s, 80s, and 90s. I've operated on several 94-year-old patients who did quite well, by the way, who knew they had these problems and were having symptoms for 15 or 20 years, but people said, oh, you're too old for surgery. So instead of having surgery when they're 70, they're having surgery when they're 85 and 90. So, age is important, but we have patients who are in their 40s who I would not operate on because of their other health issues. But we have our vibrant and active 90-year-olds who have taken care of themselves, and they deserve quality of life, and they can withstand these operations where there are no major cuts on them, where there's no severe pain. They just recover very quickly, and they do quite well. And if you have a problem, that's just going to get worse. You're not going to get any younger. Right now, you're as young as you're going to be. So this is a time to be evaluated, not see what happens in 5 or 10 years.
I'm glad you got to that because, like I said, these are comments that come to us from our viewers. We're down to the last 5 minutes of the show, and I'm really very pleased that you're our guest today because there's so much, I guess you'd say, inappropriate by the fact that there's so much advertising and otherwise about, I don't want to say the advertising is inappropriate, but there's so much out there relative to the availability of, well, I'll just swallow this, it'll be okay. You see it on television all the time. But I'm really very pleased to know about the minimally invasive techniques, the robotic surgery, which is magnificent. It's a wonderment, I believe. I'm sure it's been a wonderment to you as you've gone through your aging process, shall we say, in your profession. But it's also in listening to you, I see the advocacy that you have to want the people who are listening to understand that you're not doing it because you're required to do it. You're doing it because you want to do it, and you want to do it safely with minimal pain and excellent results. That's what I hear. Am I right on target with you?
You are on target. First of all, I went into this area because it's one of the few areas where a general surgeon like myself can take a patient whose quality of life is poor and make them better. I'm so happy I could eat pineapple again. I could go out with my friends. I could lay flat with my significant other. So we don't get that opportunity so often. But now I do this all the time and improve quality of life. But I think we also have, and as far as the quality of care, I maintain a database of my patients. We're involved in multi-institutional study to keep track of our patients and others and monitor outcomes. So we see our patients with questionnaires after the first 6 months, every 6 months, and every year afterwards to keep track of how they're doing so we can address any issues. So quality here and at the Broward Health Heartburn Center is very highly regarded. Because here we're trying to make somebody feel better. We don't want to make them worse. And that's also why we've selected some of the procedures that we do, like LINX, magnetic sphincter augmentation. It's an anti-reflux procedure that, unlike some of the old procedures we used to do, it does not often introduce new problems that had plagued some of the treatments in the past. So we keep track of what we do, and we keep improving how we do it and keep track of our patients.
Well, thank you. I think like I said, you're not only a trained, skilled physician, but you're an advocate for not only good health, but more importantly, in my mind, for your patients, which is really the process of caring for people. Why would you be a doctor if you weren't willing to care for people? So we're down to the last 30 seconds of the show, and I want to thank you for being here today. Again, Dr. Mark Shachner, you're the medical director of the Heartburn Center at Coral Springs, which is part of Broward Health System. And you're sitting right up there in the heartland, as I would call it. And I thank you very much for being here, and I appreciate the time that you've given to us. Thank you very much.
Well, thank you. Very welcome.
Folks, if you have any questions, you have any comments, there's a telephone number and an address right here. Remember, this show is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.